I will request Siddharth sir to be short and sweet.
So, so we have already discussed this in the last panel discussion, but I will just revise everyone. So this trial was presented at ASCO. It is published in NEJM, and also a subgroup analysis was published was presented at ESMO. So the standard of care for several decades was concurrent chemoradiotherapy, and the median overall survival was 25 to 30 months, with 5 years survival of just 29% to 34%. With Pacific trial, we see that after concurrent chemoradiotherapy, Durvalumab helps in non-small cell lung cancer. The same thing that we have seen that after Durvalumab along with platinum etoposide helps in improving the OS of small cell lung cancer. So this ADRIATIC trial was done with the similar design as of Pacific trial, where we have given after chemoradiotherapy Durvalumab. So there was 3 arms. One was after chemoradiotherapy, one was Durvalumab, the other was placebo, and one was Durvalumab plus tremelimumab. The primary endpoint was PFS and OS for Durvalumab versus placebo. The secondary endpoint was Durvalumab plus tremelimumab versus placebo. So these were the baseline characteristic we have already discussed in panel discussion. 70% of the male patient, 50% were PS0. Most of the patients were smoker, and 87% were stage 3 cancer patient. Carboplatin etoposide was received by 34% of the patient. Previous radiation once daily schedule was given to 73 and twice daily to 26% of the patient. Most of the patient has partial response, 72% of the patient, and 11.7% patient have complete response. What we have seen in OS and PFS was 24-month OS was 68% versus 58%, 36-month OS was 56.5 versus 47.6. In the PFS, if you see, there was much benefit, 48.1 versus 36.1. In subgroup analysis, it has almost benefited all the subgroups. We have detailedly discussed that in our panel discussion, and this was the subgroup analysis. Irrespective of the subgroup, whether they have received BID or QD-RT, once daily RT, there was benefit with the Durvalumab, and even in those who have received carboplatin or cisplatin, there was little less benefit in those who have received cisplatin, and I don't know why they have a lower PFS as compared to the carboplatin app. And similar thing was there in overall survival also. Same thing when those patients who have received PCI versus those who have not received PCI, there was benefit. So they concluded in the subgroup analysis that irrespective of the group, there is consistent benefit with Durvalumab. Now coming to the safety, we have already discussed that radiation pneumonitis was seen there in 40% of the patient in the Durvalumab arm versus 30% in the placebo arm, and those toxicities leading to death was 2.7% versus 1.9%, and immune related reactions was there in 32.1 versus 10.2. Out of this, 5.3% were grade 3 grade 4. So the most common side effect as expected from an immunotherapeutic drug is hypothyroidism, and the rest of the side effects were nearly comparable between the two groups. The safety profile also you can see, it was not much difference between the two arms. It was almost comparable irrespective of the subgroup. So these were the conclusion of the investigator, that statistically significant and clinically meaningful overall survival and PFS improvement was there, 55.9 months versus 33.4 months, and safety profile was consistent. Thank you very much.